Stenosis. So aortic stenosis is a systolic heart murmur, but what does this exactly mean? Well, systole is defined as the contraction phase of the cardiac cycle, originating from the Greek term systelin, meaning to contract. So contraction begins with the atria, which pump blood to the corresponding ventricles. The left ventricle sends blood to the majority of the body. The right ventricle sends blood to the lungs via the pulmonary trunk, which splits into two pulmonary arteries, each of which supply a lung. Murmurs occurring at any stage of atrial or ventricular contraction are deemed as systolic murmurs. But how do we tell if a murmur is systolic? There's a simple technique. Place the stethoscope on the patient's chest and palpate the radial or carotid pulse. If the murmur coincides with the pulse, it is a systolic murmur. There are several types of systolic murmurs, but the most common ones are aortic stenosis and mitral regurgitation. Other causes of systolic murmurs include hypertrophic obstructive cardiomyopathy, HOCM, mitral valve prolapse with mitral regurgitation, VSD, pulmonary stenosis, and tricuspid regurgitation. So the term stenosis in aortic stenosis means to narrow. Aortic stenosis is defined as obstruction to left ventricular outflow. We can divide the causes into congenital and acquired aortic stenosis. But before going into the causes, let's touch upon aortic valve anatomy. The aortic valve consists of three leaflets, supporting tissue, and the sinus of Valsalva, aka the aortic sinus. This is an outpouching of the aorta, which gives rise to the left and right coronary arteries. We know that the normal aortic valve consists of unfused leaflets. The right coronary cusp, the left coronary cusp, and the non-coronary cusp. The point where the ends of the leaflets meet are called the commissures. These valve cusps consist mainly of collagen and elastin, therefore defects in these materials can result in problems of the aortic valve, such as in Ehlers-Danlos and Marfan syndrome. Now, the most abundant cell type in the aortic valves are called VICs. Their job is to continuously repair the valves from day-to-day stress. Why is it relevant to know about VICs? Well, in response to injury, VICs may alter their cellular phenotype, becoming more like osteoblasts. This essentially results in a condition known as degenerative calcification, which is the most common cause of acquired aortic stenosis. Another point which links into this: if degenerative calcification occurs in the valve leaflets, due to the proximity to the conduction system of the heart rhythm may also be affected. So the causes of aortic stenosis are split into acquired, with degenerative calcification and rheumatic heart disease, and congenital, with bicuspid aortic valve. Let's start with congenital then. These include bicuspid aortic valves, which occur in 0.5 to 2% of the population. Typically, patients with a bicuspid valve do not present with symptoms until they reach the fourth decade of life. But why is a bicuspid valve a cause of aortic stenosis? Essentially, due to structural differences, it causes turbulent blood flow during systole. This results in increased wear and tear of the valve, causing early calcification, fibrosis. Unicuspid valves can also be seen in neonates and infants under 12 months. Depending on the extent, it can result in severe obstruction, being the most common cause of fatal aortic stenosis in infants. So let's now move on to the acquired causes of aortic stenosis. The most common is degenerative calcification, as mentioned before. It is important to note that degenerative calcification is entirely separate from passive age-related calcification. Degenerative calcification is very similar to atherosclerosis and involves, as mentioned before, VICs changing their phenotype into an osteoblastic form. Triggers for this degenerative calcification are thought to be wear and tear, bicuspid aortic valve, as well as genetic factors. This is a very useful picture showing how degenerative calcification takes place. As you can see, it's quite similar to atherosclerosis, involving LDL deposition and inflammatory cytokine release. The risk factors are also similar to atherosclerosis and include increasing age, hypertension, hyperlipidemia, diabetes, and smoking. Other causes of acquired stenosis are rheumatic heart disease. This is characterized by fusion of the commissures. It is important to note that rheumatic heart disease almost always involves the mitral valve first. Therefore, most patients with rheumatic aortic stenosis also have mitral stenosis or mitral regurgitation. So here we have all the causes of aortic stenosis, with each with a picture of each valve's appearance. We know that aortic stenosis is the narrowing of the blood vessels, but why does it essentially cause problems? Well, essentially with the stenotic valve, it means that there's resistance to blood being injected, blood outflow obstruction. This increases pressure in the left ventricle. Now let's step back a bit to physiology just briefly. Pathophysiology's law describes flow of fluids through a tubular system. In our case, we can use the arteries as this tubular system, and Q in this equation means flow. Okay, aortic stenosis means that flow is reduced. So to keep up with the demands of the body, other variables in the equation must counteract this drop. Without delving too much into this, P for pressure has to increase to keep up demand. The P represents cardiac output. So how exactly do we increase the pressure, therefore cardiac output, in response to a decrease in P? One way, hypertrophy. Typically, we get concentric hypertrophy due to pressure overload. This initially deals with the problem, but also reduces the capacity of the left ventricle. Hypertrophy also means that the ventricle has a decreased compliance / contractility. Combining these two factors together, we get systolic dysfunction. The end result, unfortunately, results in heart failure. To summarize, hypertrophy can only increase the pressure to a certain extent. Therefore, beyond this point, stroke volume and contractility is reduced, and therefore cardiac output is reduced. Cardiac output becomes fixed, therefore heart failure develops. Let's move on to clinical presentation. What does this look like? Symptoms and signs from aortic stenosis tend to develop gradually due to the gradual dysfunction of the heart. Symptoms include shortness of breath on exertion, as well as chest pain. Syncope is particularly concerning aortic stenosis and may occur because the stenosis is restricting stroke volume in combination with systemic vasodilation due to exercise, causing blood pressure to drop. It may also be the result of arrhythmias caused by calcification affecting the heart conduction system, resulting in a Stokes-Adam attack, which is essentially a sudden episode of syncope occurring without warning. More on the murmur ahead. So the complications of aortic stenosis therefore include heart failure, conduction defects, sudden cardiac death which ties into conduction defects, and calcific embolization. This is similar to where in bacterial endocarditis, for example, where you get calcific lumps that can dislodge from the valves and get stuck into various parts of the systemic circulation, as you also get lumps of bacteria on the valves ending up in systemic circulation in bacterial endocarditis. Let's move on to the differentials of aortic stenosis. These are mainly aortic sclerosis, hypertrophic cardiomyopathy, and ischemic heart disease. So, we know that aortic stenosis is a systolic murmur. Blood in the aortic valve is under immense pressure, and narrowing of the aortic valve would result in what we call an ejection systolic murmur. The term ejection is used to describe the characteristic whoosh sound heard on auscultation. The murmur is best heard over the aortic area with radiation to the carotids. However, high-frequency components of the murmur tend to vibrate off calcified valves and tend to radiate to the apex. This unfortunately gives a murmur similar to that of mitral regurgitation. This phenomenon is known as Gallivardin's phenomenon. A patient with aortic stenosis may also have a heavy palpable apex beat accounted by left ventricular hypertrophy. They may also have what we call a slow rising pulse. This is caused by expansion of the artery before muscular wall rebound due to volume. The force of the blood coming out of the aorta is reduced. On auscultation, we also notice that the second heart sound is absent or reduced. Why is this the case? Well, we know that the second heart sound is produced as a result of aortic and pulmonic valves closing shut to prevent backflow of blood. Due to the stiffness of the aortic valve, the sound is reduced. So investigations in aortic stenosis, echo scan. This provides the aortic pressure gradient, valve area, jet velocity, and left ventricular ejection fraction. Peak velocity and valve area are used to assess the severity of the stenosis. Peak velocity is defined as the speed of the blood entering the aorta from the left ventricle. In aortic stenosis, due to narrowing of the valve, peak velocity is increased. Try to think of this like a garden hose pipe, where squeezing the pipe results in water coming out with greater velocity. Here are peak velocity diagrams showing severities of aortic stenosis. This is one method of classifying the severity of aortic stenosis using both valve area and peak velocity. So management. For symptomatic patients, valve replacement is the only effective therapy and should be performed promptly at symptom onset. Symptomatic status of a patient with aortic stenosis can be assessed with exercise protocols. Patients who develop exercise-induced symptoms of angina, shortness of breath, or syncope should be classed as severe stenosis and referred for aortic valve replacement. Medical therapy is not effective to treat aortic stenosis. This is because patients rely on preload, stretching of myocardial fibers, to maintain cardiac output. Using drugs to reduce symptoms of chest pain or shortness of breath will adversely affect them. In addition, afterload is used to maintain blood pressure, so drugs such as ACE inhibitors are not suitable for this cohort of patients. There are no known medical treatments to slow the degenerative calcification process, the most common cause of acquired aortic stenosis. Any medical therapy, however, that is used should be targeted to treat coronary risk factors such as hypertension. So valve replacement is the golden standard of treatment. Valves can be biological or mechanical. The plus side of mechanical valves is that they have lifelong durability. However, they require lifelong anticoagulation with warfarin. This option is therefore more preferable in younger patients. Biological valves, on the other hand, require no warfarin. However, they are more likely to degrade, requiring replacement. Due to their animal origins, they are also not accepted in certain religions. The TAVI procedure can also be used to replace the aortic valve and is less invasive than normal valve surgery. Okay, that's the end of this lecture. Thank you for watching. If you have any questions, please leave them in the comment section below. Thanks again.